Alright guys, so welcome back. We're going to be finishing up block 3 and 4 over this week. As usual, just keep in mind the page number here is from an annotated first aid. So after every question I try to refer back to first aid if it's relevant, so I can show you where the answer came from. And if you ever have to ask a question about one of the questions I'm doing here, just make sure you refer to the number down here rather than the number right here. So this question, 28-year-old man develops a temperature of 103.8 Fahrenheit in Rikers after receiving a high-dose chemotherapy for acute leukemia. Lab studies show a low of pretty much everything: hemoglobin, leukocyte count, MCV, and platelet count. After appropriate cultures are done, antibiotic therapy is started because he's clearly sick. That's why he has a high fever. Administration of which of the following is the most appropriate at this time? So you know that the thing that they need to administer has to help him fight this infection. Now, of course, giving him erythropoietin and thrombopoietin would both be nice because you could fix his hemoglobin or fix his platelet count, but neither of those two things are necessary for the bacterial infection he has. Interferon gamma is specific to a very different scenario, not his. And then GCSF, granulocyte colony stimulating factor, is a set of two different stimulating factor medications that you can give to people who are undergoing chemotherapy or any other scenario where they might not have the appropriate granulocytes to fight off infection. This patient has neutropenic fever, as I wrote over there on the page. Now, of course, his RBC and platelets are low, but that is the hit you have to take when you're undergoing chemotherapy, right? That, along with the fact that you lose your hair, you lose a lot of other cells that are rapidly dividing. It's all part of getting chemotherapy, and that's something that you can't really do anything about. So you just go ahead and take the medication that you can to fight off infection and do your best to survive off of that. In the book, let me see. Right here on this page, they talk about it, right? So recombinant cytokines and clinical uses. And you have erythropoietin and thrombopoietin, which wouldn't really help our patient. It would help, but not against the bacterial infection. And then this GCSF and GMCSF. Either one of these two medications would have been just fine for him, right? So filgrastim or sargramostin. Either one of these would have been really helpful for him in fighting off the infection that he has. Next question over here, this one's pretty much about a pathology kind of thing. So 65-year-old man comes to a physician because of a 1-month history of decreased urine output and difficulty starting and stopping urine flow. Physical exam shows an enlarged prostate. His serum PSA is 12, which is much more than the normal. Prostate biopsy confirms prostate cancer. Right? Remember that PSA is more of a screening thing. It doesn't confirm anything. And sometimes people can have a high PSA even though they don't have even BPH. Screening shows metastatic disease to the L1 vertebra. The patient elects to have an orchiectomy. Which of the following changes in this patient's prostate is most likely to be increased secondary to the orchiectomy? Right? So secondary to the orchiectomy, okay. They're asking what's going to be increased. And you know that an orchiectomy is going to help him with the prostate cancer. So his prostate should be decreasing in size, right? And you can, by that theory, knock out E. What else would be increased? So this whole bromodeoxyuridine staining part might be something that doesn't ring a bell for whatever, so you just leave that as choice alone. Will cell size increase? Will DNA fragmentation increase? Or will the mitotic rate increase? Right now, mitotic rate and cell size kind of go together, and neither of those things will be increasing here. But DNA fragmentation will, because the only thing that's really going to increase is breakdown of cells so that the prostate can become smaller, right? That's what we're trying to do for our patient. And that's all going to be because the orchiectomy will lead to lower amounts of testosterone, right? Very important thing. And then one of the things you have to remember from the pathology chapter of first aid is the whole concept of DNA fragmentation, which often forms 180 base pair segments. And that's something that a UWorld question once mentioned as well. So those 180 base pair segments are something that often pop up in pathology as a result of DNA fragmentation and breakdown of cells. So let me see, right about here, I believe they mentioned it. Yeah, this thing, right? DNA laddering. fragments in multiples of 180 base pairs is a sensitive indicator of apoptosis. Okay, so if you ever get any question where they mention DNA laddering, where they're basically going to tell you that they see a bunch of fragments that are multiples of 180 base pairs, that is them talking about apoptosis, and you have to catch that. All right. This question here was a straightforward question about headaches. You have a 34-year-old man coming into the physician because of a 2-week history of daily episodes of severe unilateral periorbital headaches, right? The headaches, which develop rapidly and last 60 to 90 minutes, are often accompanied by lacrimation and nasal stuffiness on the same side as the headache. The patient had similar symptoms 2 years ago. He is currently asymptomatic, vital signs are within normal limits, physical exam shows no abnormalities. Which of the following is the most likely diagnosis? Now, they added 2 sentences here for no reason whatsoever, to really just make you read more and drain you out, right? There was no reason to tell you he's currently asymptomatic. There was no reason to tell you vital signs are within normal limits. It's really irrelevant to his presenting case. And if you're confident with your headaches, then you know from the first sentence right away that he has cluster headaches. First of all, being a man, it is more likely that he has a cluster headache rather than a normal migraine headache. Right? Migraine headaches are more so a thing that women get, right? And questions are going to tell you that a female is presenting with a migraine headache in a similar way that a cluster headache presents, because they're both unilateral, right? So you can see here migraine and cluster, both of them are unilateral. But the cluster headache is more so right behind the eye, so it causes a periorbital pain. You can have lacrimation and rhinorrhea like our guy does, whereas a migraine headache would be more so a female. It can happen to a male too, of course, men get migraines, but it's usually more of a chronic issue for females getting a migraine. And there's also often going to be this whole photophobia or phonophobia thing, right? And they might say they have the aura. There's many things related to migraine headaches. It's a very debilitating issue. But this was a very straightforward cluster headache question. This was a slightly harder question. So 25-year-old man developed shortness of breath after moving from sea level to a mining town 11,000 feet above sea level. Evaluation shows no abnormalities, but at rest, pulmonary hypertension with normal cardiac output is noted. Now, pulmonary hypertension at any point is something of concern. Pulmonary function tests are normal. Which of the following best explains the pulmonary hypertension? Right? Why does he have pulmonary hypertension? That's all they want to know. Well, it's pretty obvious why he has it, because this change from being at sea level to going above sea level causes many things to occur. But it's a physiological thing. It's not a pathological thing. Your body will eventually get used to it. So you look at all your answer choices. The first 3 are things that decreased, and the last 3 are things that increased. The very first thing you want to do is just get rid of anything that has nothing to do with, like, it's not even logically correct. And that would be answer choices C and F. There's no way this patient has decreased regional ventilation. His ventilation is not affected, right? Regional ventilation or whatever ventilation is not affected. His body, they tell you pulmonary function tests are fine. They didn't mention physical exam is fine, but it is. He doesn't have a physical issue, like his trachea being broken or whatever, right? Nothing like that. And then increased sympathetic nervous system activity. That one you can get rid of too. Sympathetic nervous system activity is not something that causes changes to your pulmonary vasculature per se. Right? Sympathetic nervous system activity would be like if you're going for a run, right, or if you're about to fight someone. That causes changes in other vasculature, but not your pulmonary vasculature, Then you're left with decreased alveolar PO2, decreased mixed venous PO2, increased pulmonary J receptor nerve traffic, and that's probably something you never heard of, and increased pulmonary vagal activity, right? So the vagal activity would be parasympathetic activity, and similar to how you were able to cancel out F, you can kind of also get rid of E, because both those things, sympathetic and parasympathetic activities, aren't necessarily going to affect your pulmonary vasculature. That's not what you're really going for. You're trying to, with sympathetic and parasympathetic activity, you're usually trying to affect your normal vasculature, not the pulmonary one. So for our patient, it is definitely true that he's going to have decreased alveolar PO2, because that's kind of what happens. So here they talk about hypoxic pulmonary vasoconstriction, also known as the Euler-Liljestrand mechanism, is a physiological phenomenon in which small pulmonary arteries constrict in the presence of alveolar hypoxia. At higher levels, right, levels above sea level, you have lesser oxygen pressure, right? So you often feel like you're kind of running out of air, and your body has to, over a period of months, your body has to adapt to it. While the maintenance of ventilation perfusion ratio during regional obstruction of airflow is beneficial, hypoxic pulmonary vasoconstriction can be detrimental during global alveolar hypoxia, which occurs with exposure to high altitude, where the HPV causes a significant increase in total pulmonary vascular resistance and pulmonary arterial pressure, potentially leading to pulmonary hypertension and pulmonary edema. So for some people who were unable to adapt to the change in altitude, this can be a problem. Very unlikely there would be a problem for a healthy 25-year-old man. This could be a problem for someone much older or significantly younger. But nonetheless, this is how NBME made the question. And NBME questions can often just be pretty trashy. So this is one of them. It doesn't really necessarily make much sense. Moving to somewhere that's much higher above sea level shouldn't necessarily kill you. And this makes it sound like he's dying, right? But you know for sure that A is a fact, because going to a higher altitude does decrease your alveolar pressure of oxygen. Question 105. A 75-year-old woman is brought to the emergency department comatose 16 hours after the onset of left arm and leg weakness. Physical exam shows left hemiplegia. A CT scan of the head shows an edematous right hemisphere. There is no evidence of hemorrhage, but there is sparing of the right occipital and midline frontal cortices. 1 hour later, she dies. At autopsy, microscopic examination of the right lateral frontal lobe is most likely to show which of the following, right? So what happened to her? So this is very similar to the progression of an MI kind of question. This is a question about the progression of a stroke. You know for sure that 16 hours ago some kind of stroke must have occurred, and that she died an hour later, so that's 17 hours. Within the first 24 hours, and this is something you have to remember, within the first 24 hours you see red neurons, and the correct answer for that is D, where they were nice enough to put the red there, right? Shrunken eosinophilic neurons. That's the first thing you see within 1 day of a stroke in the brain. After that, you start seeing the other things. So we can find that in first aid. Let me see. Not exactly the page that's written there anymore because I added a couple more pages here. But are you doing a FA 2020 version? So this basically is the 2020 version. I moved everything from FA 2020 into my annotated book rather than redoing all of FA 2020 from start. So I completely took any brand new pages in FA 2020 and put it into my annotated version. Any new images, any special notes, whatever they might have had, I moved it as I went from beginning to end of FA 2020, moved it all into my annotated version. So that's been done. So here you can see in the first 24 hours, right, you're going to start seeing these eosinophilic cytoplasm plus pycnotic nuclei, the red neurons, right? Then you see neutrophils, macrophages, astrocytes, scar, right? That's it. And you have to memorize that. You do have to memorize that. You have to know that. This progression thing is often tested, and it's not a difficult question. It's literally just whether you remember it or you don't type of question. This is a question about a study. So a study is conducted to assess the normal mean serum urea nitrogen concentration in men ages 65 years and older to be used as a reference. To be used as a reference values in a lab. What was that? A study is conducted to assess the normal mean serum urea nitrogen concentration in men ages 65 years and older to be used as reference values in a lab. Okay, so random selection of which of the following will provide an inaccurate but precise estimate of the mean serum urea nitrogen concentration in this group. All right, so they're basically saying that imagine you didn't know what normal urea nitrogen is, right? You didn't know what normal urea nitrogen levels are, but you want to know what normal urea nitrogens would be for 65-year-old people in general. who would you actually look at to get the numbers so that you could set a reference table, right? So to get something inaccurate but precise, right? This is testing you on the differences between precision versus accuracy. And this difference is something that can often be very confusing for a lot of people. There's also other words involved like reliability and reproducibility, right? That's also relevant to this stuff. You have to make sure you know exactly what the difference between all that is. So let's talk about that real quick before we look at our question, because if you knew about that part, then the rest of the question was pretty easy. There was nothing to that question as long as you remember the difference between precision versus accuracy, right? So precision is consistent and low variation. It's a very reliable thing, right? This is the consistency and reproducibility of a test. If you have precision, right? If you have precision, it means that you can keep throwing something in the same exact dot over and over, over and over. It doesn't have to land at the bullseye though. As you can see, precision is high in both of these because you were able to throw the dart at the same exact location over and over. That is precision. Here though, you threw the dart right at the bullseye, which is the accuracy part as well, right? But you can see this is high precision. Even though you sometimes miss the dart entirely, precision is simply about your reliability and reproducibility. Will you keep getting the same answer over and over or not, right? So high precision has nothing to do with getting the correct answer, right? We're thinking dead smack in the middle, that's the correct answer. Getting the correct answer is related to accuracy. Accuracy is a concept of validity, the trueness of a test, right? Accuracy requires that you get a result that hit the center, right? And most times it stayed around the center. So you can see this right side is usually the most confusing thing for most people, because you can see in both of these scenarios, right, you have one dot that hit at least the center. So then why is this left one considered high accuracy and this right one considered low accuracy? The one on the right became low accuracy because you had one shot that completely missed the whole board in general, right? So that's the concept of accuracy. Accuracy means you have to get it correct, whereas precision is just reliability and reproducibility. It's a lot of the RE, right? RE, reliable, reproducible. You will continue to keep getting your thing right at the same spot over and over again. Wherever the same spot is though, the same spot doesn't have to be the correct spot, right? That's why it's low variation. But this is correct regardless of variation, right? So you have to be correct regardless of the variation you have. But if your variation is far off from the correct, right, you even missed, that lowers your accuracy by quite a bit. So for our question, they wanted something that was not accurate, but it was precise, which means that all of these people should about have the same exact BUN, right? Have the same exact BUN. So what would it be? Would it be, now there's two sets of answers. Either patients scheduled to be examined by a urologist or patients undergoing routine health screening at a local shopping center, right? Those are two different sets of people. People who are about to see a urologist probably have chronic issues with their ureters and kidney and stuff like that. Whereas people who are at a local shopping center health screening fair are just a variety of people, right? So there's a difference here now. And we're looking for precision. We're looking for reproducibility and reliability. So we would want someone that's going to see a urologist because we're going to know all of these people are generally going to have some level of difficulty with their UN, right? The urea nitrogen. Whereas at the shopping center, there's going to be people all over the spectrum, right? So we want to have a smaller spectrum. We don't want much variation. And inaccuracy also falls under that because accuracy is variation. Inaccuracy, in the whole concept of accuracy, you can have variation. Here, we don't want accuracy at all, so we will go ahead and not have variation. So the only answer choice to pick here was just C. Of these 500 people that are going to be examined by a urologist, majority of them will have the same urea nitrogen, and it's going to be a bad urea nitrogen because they're all sick, right? And they're all coming to a urologist for a reason. 10 people is a smaller number, so that's the only reason, you know, A is wrong compared to C. That's nothing else to it. these 10 people could all actually provide a very accurate answer, and they could all just have the same exact urea and nitrogen. So you want to have more people. That's definitely one way to go with it. If you wanted something very accurate, you would pick this one. Right? 10 people could all have the correct, valid, wrong, bad urea nitrogen level at this urologist center. Right? 10 people at a local shopping center could also have an accurate urea nitrogen level, right? But then you would have to wonder, do you want accurate and precise, accurate and not precise, right? There's a bunch of differences. And often NBME repeats questions, so this is a question that can be rewritten, right? Where the next time they can ask you, provide an accurate but unprecise or imprecise, or whatever the word would be for that, right? So something that is accurate but not precise. So then at that point, what would you pick as your answer choice, and so on and so on. That's different ways they can try to go ahead and change this question up. So make sure you do have that memorized and understood very, very well, so that on your own test day, you don't feel confused about what was the difference between accuracy and precision. Okay, Rose Gold, hi, Mir, help, you're good. Are you going to make a video on you? I might, I'm not sure. I don't feel like it's relevant to any of us. Do the questions get harder depending on how well you answered the previous question along the exam? No, this is not a dynamic exam. Want to know if USMLE questions are different between URL Step 1 and URL Internal Medicine. I don't know about what you mean by URL Step 1 versus URL Internal Medicine. But the test is not a dynamic exam. That's only as far as I know, the NCLEX is like that. But Step 1 is not like that. The questions are already there. They don't get harder or easier based on how you're doing on them. So yeah. But the pass-fail concept thing has nothing to do with most of us that are actually studying right now. It's got something to do with someone that might be starting med school this year, so they can worry about it. It really has nothing to do with us, though. Alright, 107. Left radial arterial and venous blood samples are drawn from 10 chimpanzees breathing room air while resting quietly. Okay, so breathing room air while resting. The results indicate that the total carbon dioxide concentration average is 21.5 in the arterial sample and 24.3 in the venous sample. Which of the following accounts for the larger amount of carbon dioxide in these venous blood samples, right? Why is there more carbon dioxide in the vein? So you look at all your answer choices. CO2 bound as carb aminohemoglobin, dissolved CO2 in the plasma, dissolved CO2 within the erythrocytes, bicarb transported in the plasma, and bicarb transported within erythrocytes. And this is a question directly about the Bohr-Haldane effect, but you would have to remember the percentages of what's more commonly done. How is carbon dioxide actually moved around? What is the right answer for which one, the last one? This one was C. The right answer is always written right there. So 500 men who are about to visit a urologist, right? Because they would all have a very precise answer. They would all have the same kind of answer. It doesn't necessarily have to be an accurate answer, though. But they're all definitely sick. So here we need to go back and revisit the Bohr-Haldane effect. What did I write down? What page? 737. Okay, so it's probably like 740 now. Where was it? Bohr-Haldane. All the page numbers changed ever since I wrote that explanation page out. Okay, here we go. So the carbon dioxide transport, right? They tell you majority of it, you see, you have to remember this. Majority of carbon dioxide is transported as bicarbonate, not as carbaminohemoglobin, nor as dissolved CO2. You see how the carbaminohemoglobin is about a quarter of it, and this is only about 7%, right? Majority of it is as bicarb. So the answer you would pick would have to be the bicarb, and it will be the bicarb in the plasma. Majority of carbon dioxide molecules are carried as part of the bicarbonate buffer system. Carbon dioxide diffuses into the red blood cells, and carbonic anhydrase is a big part of this. So if you remember that bicarb was the majority of it, then you would just get this right just based off of that. There was really nothing else to know for this question. It was a test on this page. That's it. Whether or not you know how this page works. And you have to remember that the Bohr effect is about bringing things to tissue, right? And the Haldane effect is about bringing things back to alveoli, picking up oxygen and bringing back CO2, right? Very basic concept, but make sure you know what's happening here. And then the only thing I added onto this page was the chloride shift, something that the UWorld had a question about, right? And first aid does show it to you, but they don't necessarily label it, right? So this is your chloride shift right here. Next one. Oh, this was a pretty nice question. So this is something you probably haven't seen before, right? But I did find pictures for it online. I put that here as well in the explanation. So you can see there's a difference between these pictures. It's right here, right? You take your splenic vein and you connect it to the left renal vein. That is a real surgery that can be done to deal with this kind of issue. A 48-year-old man is brought to the emergency department because of a 1-hour history of vomiting blood. And anytime you see a question about vomiting blood, you immediately want to think of some kind of portal hypertension issue. 1 year ago, he was diagnosed with bleeding esophageal varices and cirrhosis. So now that further confirms there's some sort of portal issue. Variceal banding was ineffective in controlling the bleeding from the varices. Physical exam shows ascites, and ascites is a giveaway for issue within the liver, right? In the portal triad stuff. A surgical shunt between which of the following veins is most likely to relieve the esophageal bleeding in this patient? Now, they chose a shunt that we're not used to seeing, but it is a doable shunt per se. I don't know how nice this shunt might be and how effective it might be, but it is definitely doable. Main point is, though, you had to pick an acid choice where there was a shunt between a portal system and a systemic system, right? So if you see two acid choices that are both portal or both systemic, or sorry, if you see any acid choice where both things are portal or both things are systemic, that acid choice wouldn't make sense, right? So the only choices you were left with at that point were B and C, right? Because hepatic and inferior phrenic don't make any sense. Superior epigastric and inferior epigastric does not make any sense. This is not a portal systemic anastomosis at all. Superior rectal and superior mesenteric vein, again, that's also not going to help in any way whatsoever. So you're left between splenic and left renal, which is a portal systemic shunt, or ileocholic and inferior mesenteric, which would also be a portal systemic shunt. Now, these portal systemic shunts are not exactly the easiest thing to remember, but GIT overall is not a difficult chapter. It's more so a chapter of memorization. So you would have to sort of memorize this, right? Your portal flow looks like this. This is your entire portal system down here, right? There's a bunch of veins, and not all the different names are necessarily things you have to memorize, but you should know them. You should know that they exist. You don't have to memorize them. So you can see the ileocholic vein is right here, right? And that is a part of your portal venous system. Okay. Doing shunts often involves connecting this with any systemic vein. So any vein that hasn't been listed on this image right here would be a systemic vein, right? And I put that same question we had kind of over here too, right? The splenorenal shunt. This is an even better image of your splenorenal shunt. Right? So it's a very common thing to do apparently, connecting the portal splenic vein to the systemic renal vein to relieve pressure in the varices due to portal hypertension, right? And anybody with liver disease. Very common thing. And here they list out other portal systemic connections that can occur, right? In the esophagus, you have your left gastric and azygos. In the umbilical area, you have your paraumbilical and small epigastric veins. And in the rectum, you have your superior rectal and middle and inferior rectal veins, right, connecting. Very important page to master. You want to go ahead and make sure you spend as much time as necessary on this page to make sure you get all of this down. I don't have any ready right now, but you can definitely go ahead and Google it. You would find it. And then I also did a good video on it. So we're only recently getting up to Bohr-Haldane. I'm not done with the respiratory videos in my full mastery playlist, but when I discussed it, I did go through it in pretty good depth because it's a fairly easy topic to know, but you want to make sure you do actually know it. So I did have a lot I talked about regarding the Bohr and Haldane effect and how it's going to show up in questions. So yeah, I mean, you can always YouTube to search more things too, but my last respiratory, what is this? The last respiratory physiology video would have more information on the Bohr-Haldane effect. So this was just answer choice D. And this one here was just C, splenic and left renal. The splenorenal anastomoses, like this. Okay. 109. A 35-year-old man comes to the physician because of a one-day history of pain and swelling of his right great toe. So that immediately kind of makes you think of gout, right? Pain and swelling of the right great toe. Examination of the toe shows erythema, swelling, warmth, and tenderness, all of which still fits with gout. Movement of the toe is limited by pain. Microscopic examination of the aspirate shows numerous neutrophils and needle-like crystals, still going with gout. Which of the following is the most likely cause of his swelling? So swelling, they're really just picking on what's causing the swelling. They're not even asking a question about the gout anymore, right? The actual question, like they presented a scenario about gout, but the question they're asking, always remember this about any test you take, that final sentence that has the question might be completely irrelevant to the rest of the entire paragraph, right? So anyone could have asked you this question by simply saying what usually causes swelling, right? And then you would look at your answer choices, and swelling is due to increased vascular permeability, right? More blood can actually go into that area and permeate through the vascular area. Right, so this is a case of acute gout. Monosodium urate crystals are taken up by neutrophils, leading to acute inflammatory reaction. That inflammatory reaction is what causes increased vascular permeability, leading to swelling. Right? T cells are not really involved in gout. They're more of a rheumatoid arthritis thing. So answer choice E was completely irrelevant. And that's really all there is to it. You can also think about how the neutrophils got there. So that is also increased vascular permeability, thanks to things like interleukin 8, right? So something like that. But the other answer choices don't really make any sense. Complement activation has nothing to do with this. Release of lipopolysaccharide has nothing to do with this, unless he had some kind of infection. But they don't mention anything for you to think he has infection, like a fever or whatever. Histamine is not really related to swelling as much as it is related to flushing. Okay, so that would not fit at all. This was a very straightforward question about vaccinations, and this is kind of something you can expect on your NBME as well as your Step 1. An investigator is studying the efficacy of distinct vaccine formulations directed against the capsular polysaccharides of Neisseria meningitidis. The carbohydrates are chemically conjugated to various compounds and injected into lab mice. Titers of anti-capsular IgG antibodies are then measured. Which of the following compounds is most likely to induce increased titers of these antibodies when conjugated to the polysaccharides? Right? So this question might sound like complete gibberish to anyone who hasn't really studied immunology and microbiology a lot. Otherwise, it's a pretty straightforward question asking you about how conjugated vaccines work, right? So capsular polysaccharide vaccines are often conjugated to proteins to improve immunogenicity. That protein acts like the antigen, right? Because a capsular polysaccharide doesn't necessarily act like an antigen. Flagellin is the only answer choice that's a protein from all of these answer choices. None of the other things are a protein. This would be a subunit vaccine which is used for HBV, HPV, acellular pertussis, Neisseria, like in our question, strep pneumo, and Hib. Right, so in immunology, they talk about that. And UWorld has excellent questions about the same topic as well. Right, so our guy was, what was it? Subunit vaccine. Right, subunit. Includes only the antigens that best stimulate the immune system. Right? And you can combine these things. You can combine some of these to do other stuff. So for our guy, they took the Neisseria meningitidis. What is it? Carbohydrates. Yeah, the carbohydrate capsule. Yeah. And that capsule, IgG antibodies are going to be formed because of it. That's it. It's a very straightforward question. Nothing crazy happening on this page, but of course they chose answer choices that would kind of throw you all over the place and really make you think hard. But there's nothing to think hard about in this question. So don't skip anything. There's a lot of stuff to know. You want to make sure you don't overthink about it. This question 111, another microbiology related topic. 21-year-old man is brought to the emergency department 45 minutes after sustaining multiple injuries in a motor vehicle collision. Blood pressure is pretty low. Physical exam shows diffuse abdominal tenderness. He's diagnosed with laceration of the spleen and undergoes splenectomy. The splenectomy most likely predisposes this patient to develop future infection with which of the following causal organisms. Now, generally speaking, we know splenectomy predisposes patients to be infected by encapsulated organisms, right? And in our answer choices, there's two. There's E. coli and strep pneumo. They're both encapsulated, right? So theoretically speaking, there are two correct answer choices. And NBME is notorious for doing something like this. But they can do it because they're asking the question in a very realistic way. The splenectomy most likely predisposes him to what? And again, I personally think it wasn't worded correctly because it doesn't. They're asking you most likely predisposes him. Well, it predisposes him to both, so the correct answer is both. But which one will he most likely actually get infected by? It would be strep pneumo, right? Because a 21-year-old man is very unlikely to get infected by E. coli, but a 21-year-old man of any type, whether he be healthy with a spleen or without a spleen, can get infected by strep pneumo, right? And then a person with a spleen would be able to fight it off, whereas a person without the spleen would not be able to. So that's one thing. And then, of course, the patient just had a car accident, got a splenectomy, right? But again, splenectomies are a very weird thing on the NBME and not so much on UWorld or Step 1. In UWorld and Step 1, you can assume that after the splenectomy was done, the patient was vaccinated against all things that he can get issues from, right? But on NBME, apparently these doctors aren't educated enough to do what they're supposed to do post-splenectomy, right? So don't assume that on your NBME. If someone got a splenectomy, it means they are now susceptible to encapsulated organisms, and they were not vaccinated, unless otherwise told in the question. 112, a 17-year-old boy has the acute onset of lethargy, sore throat, and fever. Physical exam shows symmetrical, non-tender cervical lymphadenopathy, and exudative erythematous pharynx, pallidal petechiae, and splenomegaly. So a 17-year-old boy would be someone who would get Epstein-Barr virus, right? And the non-tender cervical lymphadenopathy is the real giveaway for it being mono, right? Induced mononucleosis. No rash is present. Serologic studies are positive for antibody to Epstein-Barr virus, which they gave away for some reason in this question. In addition to a slightly decreased platelet count, the peripheral blood smear will most likely show an increased number of which of the following. What would you see more of in the peripheral blood? So this was a very easy question because, of course, someone with a viral infection would have more lymphocytes, and that's really all you had to pick. The harder version of this question is what's on UWorld and what will be on your Step 1. So they might give you a peripheral blood smear, and they can show you this kind of image. Let me show you what it would be. So we're looking at Epstein-Barr virus, okay? Where did it go? Did I skip it? Epstein's bar. Oh, right here, sorry. Okay. So Epstein-Barr virus, they can give you an image like this, right? And then they can ask you, what is this one? Right? And then you would have two answer choices that you'd be between. You'd be either thinking that this is an infected B cell or it's a reactive T cell. You know, obviously these are both lymphocytes for sure, but of course on histology like this, you can't differentiate between a B or a T cell. This one, in a patient with Epstein-Barr virus, is actually a reactive T cell. An infected B cell does not look any different. Okay, that's something you have to make sure you remember. This is the other way around when you talk about this disease, PCNSL, right? Primary CNS lymphoma. In CNS lymphoma, this would be the infected lymphocyte, not a reactive one. All right. It's a very important little topic that you want to make sure you don't get wrong. The other thing is the mother of such a patient, 17-year-old guy having a sore throat and fever, the first thing that the mother can do is just give him amoxicillin, if there's any left in the house, right? Using amoxicillin in a patient with mono actually ends up causing a rash. Right? You have to make sure you remember that too. It's a very nice little topic that you can get a very straightforward question on, and obviously a tricky topic, right? So make sure you're ready with that. This question itself, though, was a very straightforward, easy question about the immunological aspect of how viral infections actually work. Right? So nothing crazy there. Okay. Next one, 113. 22-year-old man has had frequent episodes of cutaneous urticaria and occasional episodes of laryngospasm over the past year. An allergy evaluation fails to find any allergic cause for his urticaria. Based on this history, which of the following complement proteins is most likely to be deficient in his serum? And so what is he missing? And they kind of gave away the diagnosis by saying he has some kind of deficiency. This question, however, is kind of an error. All right, this patient presumably has hereditary angioedema, which is what they're hinting at when they say he has a deficiency of which complement, right? So the only complement you could be deficient of and present with something similar to urticaria would be C1 esterase inhibitor deficiency, right? If you're deficient of that, then you can get hereditary angioedema. However, hereditary angioedema does not have a rash, right? That's the main differentiating point between angioedema and allergy. So it's a very weird question. I believe it's a wrong question, but the correct answer here is A. It's just that I feel like the whole question is just wrong, right? And this is something that everyone on the internet did say. So again, you can't really do much about it. Things like this can pop up, and of course, if you do see something like this on your test, you would pick A because the other answer choices don't make any sense whatsoever. But again, theoretically speaking, neither does answer choice A. But it's the most sensible wrong answer choice you can pick. All right, so here, C1 esterase inhibitor deficiency, right, characterized by low C4 levels as well, right? And that was why this other one, C4 binding protein, is just a trick answer choice, right? Low C4 levels. But the main thing here is a deficiency of C1 esterase inhibitor. Right, causes hereditary angioedema due to unregulated activation of kallikrein, leading to more bradykinin, characterized by low C4 levels. ACE inhibitors are contraindicated because ACE inhibitors also increase bradykinin. Right, administration of C1 inhibitor or kallikrein inhibitor would help, and danazolol or stanozolol, or two more medications that UWorld lately mentions, can help. But they're not in the book or anything. Alright, so C4 levels are low here, and that was not an answer choice either. There were no answer choices about C4 levels per se. C1 esterase inhibitor deficiency would fit the correct answer though. Alright, but again, bullshit question because it's pretty much just wrong overall, so can't really learn anything from that question. This is an anesthesia question. Very rare of NBME to kind of ask about stuff related to this topic, but here's one. 4-year-old girl is conscious but unable to breathe spontaneously for 3 hours following uncomplicated removal of a branchial cleft cyst. The procedure was done under general anesthesia with sevoflurane, which is a terrible anesthesia to use. Succinylcholine was administered for intubation. Which of the following is the most likely cause of the prolonged apnea in this patient? So you look at all your answer choices, you just go ahead and pick one that would cause prolonged apnea. But you don't really see one. You don't see one that directly says, oh, here's something that would cause prolonged apnea. The other issue is that the correct answer in this book is actually, the correct answer of this question is not actually discussed in first aid, right? So this is something you might have heard of in either a Kaplan lecture you might have listened to, your professor might have taught it to you, but that's really rare. Professors don't often teach much in med school, depending on where you went. You might have learned it from USMLE RX. That's something you can do, right? But nowhere do they really talk about that, except for a little bit over here. Right, so local anesthetics. Let me see. Do they mention it? You can give it as epinephrine. No, not really. Right. And here in this area right here, I wrote it here, but they don't really mention much of it here either. Right, so succinylcholine is not metabolized by acetylcholinesterase, so it stays at the receptor for a long time. It is actually metabolized by plasmacholinesterase, which is called pseudocholinesterase. If you have pseudocholinesterase deficiency, which is acetyltrace D, right, people with pseudocholinesterase deficiency may not be able to move or breathe on their own for a few hours after fast-acting drugs such as succinylcholine and mivacurium are administered. All right. Choice A and E are related to malignant hyperthermia, so they're both wrong, and you can just ignore both since they're both talking about the same thing. Choice B just makes no sense because the vagus nerve does not affect the diaphragm, the phrenic nerve does, right? So then at that point you'd be left with C and D, and midazolam, overdose with midazolam as a preoperative sedation. Very unlikely kind of thing for this question, but again, at least you're down to a 50-50 breakdown. Right, but this is pseudocholinesterase deficiency. Okay, anesthesia is a pretty big topic. In my neuro videos, I did a whole lecture on like understanding the general principles of anesthetics, because this is like the first chapter of first aid. We're in the pharmacology section and they're teaching you brand new stuff, right? So you have to understand how all of that works. This bold sentence here, right, kind of gives you an idea of how all of that is kind of going. You have to spend some time really grasping anesthesia well, right? Getting a good idea of what everything means, because questions present in weird ways, and you won't know whether it's slow onset of action, high lipid solubility, low lipid solubility, blah, 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 all those different things. After that, even, you have this whole concept of local anesthetics with the 2 eyes or 1 eye, so you can differentiate between them, right? More information about pseudocholinesterase over here as well. Right, break down products of PABA, and being able to use epinephrine to enhance local action is another thing that you can get a question on. And the last anesthetic thing you get questions on are the neuromuscular blocking drugs, because there's this whole concept, you might have seen this question on UWorld already, about the train of force stimulation. Right, very important to know the difference between this fade or constant but diminished. Right, whether you're in phase 1 or phase 2. A whole bunch of stuff about succinylcholine is a very big topic, definitely a high yield medication. So if you haven't studied it, then this would be a rather difficult question for you. Otherwise, it's pretty much just pseudocholinesterase deficiency. That's the only reason succinylcholine was administered, but then this patient's still not back to normal yet. Okay. 115, excuse me. A 64-year-old man with bronchospastic pulmonary disease continues to have wheezing in spite of increasing doses of a beta-adrenergic agonist inhaler. He is hospitalized and systemic prednisone is admitted to the regimen. Which of the following best explains the action of prednisone in enhancing the response to the beta-adrenergic agonist? Right? How is giving prednisone going to help? So, cortisol, as written down here from UWorld, cortisol exerts a permissive effect on many hormones to help improve the response to a variety of stressors. For example, cortisol increases vascular and bronchial smooth muscle reactivity to catecholamines, right? And a beta-adrenergic agonist inhaler will work much better with the systemic prednisone. That would be answer choice B, enhanced action of the agonist at beta-adrenergic receptors. The other thing is you want to think about what the physician is trying to do here for our patient. So you would love if B was a true thing. If B is true, then that would completely make sense why we're giving these two medications together to our patient with bronchospastic pulmonary disease, right? Enhanced absorption of the agonist doesn't make sense because it's an inhaled, right? It's an agonist inhaler. It'll work at the surface. It's not saying you have to absorb per se. Inhibited excretion of the non-metabolized agonist is irrelevant. Inhibited metabolism of the agonist is irrelevant. And inhibited metabolism of the metabolites of the agonist, again, this whole, C, D, E are just really answer choices they kind of just made up out of their ass for that, for the most part. Completely irrelevant stuff, right? You do need to know this whole concept of things that are permissive together, right? So drug interaction types and then the whole concept of cortisol. So let's look at cortisol real quick, because that's a really big hormone that we all deal with every day, especially if you're studying for step 1. Cortisol right here, right? Blood pressure upregulates alpha-1 receptors, causes insulin resistance, upregulates gluconeogenesis, decreases fibroblast activity, decreases inflammatory and immune responses. And that's kind of another thing that would help. Decreasing the immune response can help in patients with asthma, for example, who would also take a similar inhaler. And decreases bone formation, right? So you can see right here, this increased sensitivity to norepinephrine and epinephrine, this permissive action, is what the question was about. Right, it's a very nicely done question. Simple, does the job. 116 is another micro question. 67-year-old man comes to the emergency department because of a 2-day history of fever, sore throat, and difficulty swallowing. So a very old man with fever, sore throat, and difficulty swallowing. He has lived in various homeless shelters during the past year. Temperature is high. Physical exam shows erythematous tonsils with a small area of gray exudate. That gray exudate kind of gives away what's happening, but the next sentence itself gives away what's happening. A throat culture grows Corynebacterium diphtheria. This pathogen produces diphtheria toxin, which blocks which of the following cellular processes? So you have to remember the elongation factor 2, EF2. How you remember it is up to you. For Corynebacterium diphtheria and Pseudomonas aeruginosa, Sketchy Micro has the same accordion in the image. So that kind of helps you remember it for one thing. But again, feel free to use what you can. So this accordion right here, right, with this bow to remind you of ribosylation, right? So it's elongation factor 2 gets ribosylated, right? Ribosylation of elongation factor 2 is the main issue, and this is the gray exudate kind of stuff they're talking about, right? Corynebacterium diphtheria is a very high yield bacteria that you get questions on. So ADP ribosylation of elongation factor 2 is the main issue there. And without elongation factor 2, you can't do translation. So that's the pathogenesis of that aspect. And many people didn't actually remember that. Many people didn't know. Like, you can remember ADP ribosylation of EF2 happens, but what does that lead to a problem with? Well, the whole sentence is that this potent exotoxin inhibits protein synthesis via ribosylation of elongation factor 2. And protein synthesis itself is a mixture of transcription and translation, but the real issue is with translation. Translation is not working. Right, there's a bunch of other things you can get questions on. The cystine telluride auger. You can get a question on the elect test, which looks like this. Right, all kinds of things. So you got to be ready. Know your stuff. 117. What happened here? 7-year-old boy is brought to the physician by his mother because he has difficulty concentrating in school. Mother says that he feels tired all the time. Physical exam shows normal development. Lab studies show a mild hyperchromic anemia and an increased serum creatinine concentration. So increased creatinine means some kind of renal issue. And anemia, which is also renal. Further lab studies are most likely to show which of the following additional abnormal concentrations in this patient. So, a 7-year-old, and they don't mention that he's an immigrant or anything like that, nor does it seem like he has any major vitamin deficiencies. When you look through your answer choices, the only answer choice that could make sense for why he might be having what seems like a neurological issue would be the increased blood lead. This was a very easy question. Right? Lead toxicity is the reason he's basically becoming less capable of developing his mind, developing his brain, right? And then, of course, lead poisoning is also related to anemia, which he has, right? Lead toxicity causes disruption of heme synthesis via inhibition of ALA, aminolevulinate dehydratase. And you get anemia, basophilic stippling, colic, diarrhea, encephalopathy, foot drop, gum deposits, growth retardation, gout, and hypertension, right? This is the whole ABCDEFGH concept of memorizing all of this. The other answer choices are kind of explained by whatever I wrote for the rest of them, but it was impossible for you to pick any of these other answer choices. There was just no reason to. Literally no reason to, right? It's a typical school kid with lead poisoning. They might live in a really old house or something. This was a very interesting question, important question. All right, so this is one that will be something you should keep in mind, talk about, and raise awareness of with your other fellow so you can all remember this. 55-year-old man with hypertension comes to the physician because of severe headaches and confusion during the past week. He smoked a pack and a half of cigarettes daily for 30 years. So you can basically just call that 2 packs daily for 30 years. Blood pressure is 190 over 110, which is super high. You hear a faint bruit over the left abdomen, so you know something's wrong with his aorta. A captopril renal radionuclide scan shows delayed function in the left kidney. Okay, which of the following findings is most likely on abdominal aortography? So since there's delayed function on the left kidney, the bruit is on the left abdomen, it must be on one of the vessels coming right off of the abdomen, right off of the aorta, which would be the left renal, right? Either left renal artery or left renal vein. Okay, so you look at all your answer choices. You have aortitis, which would not be the answer here at all. Aortitis would be something you would think of for maybe syphilis, but not this. Left renal artery aneurysm, left renal artery atherosclerosis, left renal artery dysplasia, and left renal cell carcinoma. All right. Which of the following findings is most likely on aortography? So renal cell carcinoma has a tendency to invade the left renal vein, and that's something that Pathoma teaches, and you also have to kind of make sure you understand that. The reason this happens, and it's a very simple concept, any organ that has a cancer to it, when the blood leaves the organ, that's where the cancer is leaving the organ, right? And then it's going to go to the other parts. So, of course, blood leaves any organ through the vein, right? So left renal vein. That's something you can just easily remember. Thankfully, none of the answer choices had vein in the answer choices. But it does have an association with obstructed drainage of the left spermatic vein leading to a varicocele. Renal artery stenosis is more commonly due to atherosclerosis or fibromuscular dysplasia. Right? And here, for our patient, let me just check this real quick because I'm trying to see what's happening in this question. Just want to make sure because I don't know what I'm talking about in this explanation over here. This one was left renal artery. Yeah. And so this is just atherosclerosis. Right? He doesn't have he definitely doesn't have an aneurysm, that's for sure. This is not an aneurysm, doesn't present with bruit. You have to remember that even a AAA, right, abdominal aortic aneurysm, that's a whole different thing, right? But this is not an abdominal aortic aneurysm. This is an old man who has something going on with the left kidney. That's why they added this entire concept of the left kidney here. And it wasn't going to be left renal cell carcinoma. If it was the carcinoma, then it would be the left renal vein. A lot of people picked E. They thought it was a carcinoma, but it wasn't. Right? That's not what happened here. Something is wrong with his left renal artery, not the left renal vein. And this guy most likely has left renal artery atherosclerosis, which is why also his creatinine is high. Right? His left kidney is just not working right. That's it. Nothing else is really the bigger issue here. Now, it can be argued that this question is not very accurately written, and that this question is one where you could think E is a very viable answer choice, but I'm pretty sure a left renal cell carcinoma question would present in a different manner, not just with someone having hypertension and a bruit. That would not be enough. Okay, but hypertension and a bruit is enough for you to pick atherosclerosis. Very common thing, right? And the chronic smoking is more inflammation of that artery. So inflammation is one of the pathogenesis things for the development of an atherosclerosis or an atheroma. But very good question though. Very good question. Just make sure you remember the whole vein part, this concept, so that you wouldn't really pick left renal cell carcinoma. No. 119. A 60-year-old woman with psoriasis comes to the physician because of progressive joint swelling and pain of her hands during the past 6 months. Psoriasis and pain. Okay. Physical exam shows joint tenderness and effusion. She asks for treatment with methoxycillin and ultraviolet A light, which worked well for her similarly afflicted sister. Okay. This therapy would be contraindicated in this patient if she were to have which of the following conditions? So who would you not give methoxycillin and PUVA, ultraviolet A light? So you look at all your answer choices, and you have to remember PCT is the photosensitive one. PCT is the one that has a, so the various porphyrin issues are actually very easy to memorize, but you have to spend some time on actually doing it. Otherwise, it obviously won't come to you naturally. So let's find that real quick. Porphyrinias, where were they? Okay, right here. So lead poisoning is the whole different thing that we already talked about, right? We're looking at between AIP and PCT. AIP is the one that has the 5 P's to it, but one of those P's is not photosensitivity. Porphyria cutanea tarda, because it has the cutanea in it, you can remember the photosensitivity, cutaneous photosensitivity. PCT is the one that's all about the C. You have to remember the name of the enzyme, uroporphyrinogen D carboxylase, like I did here. You have to remember the cutaneous aspect for cutaneous photosensitivity, and you have to remember that it is associated with Hep C. Okay, and that if our patient has porphyria cutanea tarda, then we can't give her ultraviolet A light as a treatment, right? And it's not really something you give as a treatment. It would be more so something you would tell her to do, like, oh, go sit in the sun for longer periods, go sunbathing or whatever. We can't tell our patient that if she has PCT. This was really a very elementary way, a very lame way of asking a question about PCT, to be honest. But again, it's a fair question, if anything. Last one for this video, number 120. An 83-year-old man, so very, very old man, comes to the physician because of a 3-day history of painful blisters on his torso. Pulse is 72 per minute, blood pressure is 125/80, so that's normal. Physical exam shows numerous 0.5 to 1 centimeter clear, fluid-filled, tense blisters over the trunk. Histopathologic examination of a biopsy specimen from the affected area shows subepidermal blisters. Production of autoantibodies directed against which of the following structures best explains the findings in this patient? So you look at your answer choices and you see bullous pemphigoid antigen. And that should remind you of bullous pemphigoid and pemphigus vulgaris. Our guy definitely doesn't have pemphigus vulgaris. They're describing bullas, right? The clear, fluid-filled, tense blisters, those are bullas. He has bullous pemphigoid. That would perfectly make sense. That would further be confirmatory with the subepidermal blisters, right? He has bullas, not the more vulgar thing, which is the pemphigus vulgaris. Now, of course, they were very clever with the answer choice, right? Bullous pemphigoid antigen is the correct answer, but the better answer choice would have been for them to just put hemidesmosomes, but they didn't put hemidesmosomes. They put bullous pemphigoid antigen, right? They do that. They will. It's like NBME lingo. They'll often change something very obvious into something even more obvious, something that you might not have actually seen before. And you might even go so far as to think, what the fuck is bullous pemphigoid antigen? And then you get rid of it. The bullous pemphigoid disease antigen is whatever the antibody is attacking. The antibody is attacking hemidesmosomes. Right, so that's all this was about. Nothing else to really know here. Definitely make sure you know the difference between bullous pemphigoid and pemphigus vulgaris. Pemphigus vulgaris is vulgar. It's a lot more problematic. Your skin is completely ripped off and separated from each other as well. So let's take a look at it real quick. So right here we can see the differences, right? Bullous pemphigoid is below the epidermis, right? And you can see how there's a segregation of the dermis and epidermis. It just comes off. And then, of course, fluid can accumulate underwards. And this is how it looks like. So this is the kind of stuff that our patient in the question just had all over his back. In here, pemphigus vulgaris, this is potentially fatal. It's really problematic. What happens here, of course, this is most commonly seen in older adults, and our patient was an older adult, but he didn't have this. He didn't have antibodies against desmoglein 3. And was that an answer choice? It wasn't even an answer choice. Right, desmoglein 3, a component of desmosomes, which also weren't an answer choice. They had desmoplakin, whatever that is. And it is a thing. You should make sure you know what desmoplakin is too. So in this one, pemphigus vulgaris, you can see this net-like issue because all the different cells are unable to stay stuck to each other, so they all separate. Whereas before, in bullous pemphigoid, it's just a difference between the epidermis, the dermis and epidermis being stuck together. Right, so below the epidermis, not the dermis and epidermis, excuse me, the epidermis and what's below it, the basal membrane between those two guys sticking together. And you can get all kinds of images. These are histopathological images showing you. And so here in the bottom one, you can see this one will be bullous pemphigoid, where the epidermis is not stuck to the basement membrane. But this one here will be pemphigus vulgaris because you have the epidermis stuck to the basement membrane, but the cell is just tearing up. Right? The epidermis itself is tearing up. Big difference between the two histologically, and of course in images like B and D, right, with the immunofluorescence, because you can, with the immunofluorescence, you can see the actual antibodies doing their job. That's a very significant, problematic disease, and you have to make sure you know it. Right. So I'll stop here for now, and then in the next video, we'll continue on from question number 121. Thanks a lot for joining. Keep studying, guys, and I'll see you again soon.